right, good morning, everyone. My name is Rob Allen. I'm the Chief OEM resident here at Johns Hopkins. I'm excited to introduce our last group of the session here. So I don't know that early. I'll save it for last time. So we have Dr. Kylie Courtwright. She joined the Inova Health System in September 2024 as a sports medicine neuropsychology fellow. Dr. Courtwright obtained her doctoral degree in clinical psychology with a neuropsychology focus from Pacific University after completing a pre-doctoral internship at the Veterans Health Care System of the Ozarks in Northwest Arkansas. Prior to graduate school, Dr. Courtwright obtained her Bachelor's of Science in Forensic Psychology from Walden University. She was enlisted in the U.S. Navy for 6 years. She has presented posters at national conferences and has published in peer-reviewed journals with a primary focus in general neuropsychology. She is currently engaging in research in more specialized in sports-related concussion. Dr. Gianna is a neuropsychology postdoctoral fellow at the Inova Sports Medicine Concussion Program, started in 2020. Dr. Hill graduated from the University of Michigan with a Bachelor of Science degree in biopsychology, cognition, and neuroscience. She obtained her Master's of Science degree in kinesiology with a focus in biobehavioral exercise from the University of Illinois. Dr. Hill earned her doctorate of psychology with an emphasis in neuropsychology from Adler University upon completion of her neuropsychology pre-doctoral internship from the Kansas University School of Medicine, Wichita. Dr. Hill is passionate about providing quality patient care to patients across the lifespan, but is particularly interested in neurodevelopmental disorders and brain injury in children, adolescents, and young adults. Brett Gustman is a state licensed and nationally certified athletic trainer who joined Inova Sports Medicine in 2016. With nearly 20 years of experience, Brett is committed to providing comprehensive post-injury concussion care to his patients. Additionally, he serves as the outreach coordinator where he plays a pivotal role in building relationships with local sports organizations, law enforcement agencies, first responders, schools, and other healthcare providers. His efforts are aimed at enhancing Inova's impact on promoting safety and wellness, specifically through concussion education lectures and baseline testing. So without further ado, please welcome the group to stage today. Thank you.
All right. Well, sorry, that took up all of our time for talking and all of our introductions there. My name is Brett Gustman. I'm the athletic trainer. Please continue to me. That's totally fine. I'm married for 23 years. I'm used to know everything or anyone I talk to. But thank you very much for coming today, and thank you for staying. I know we're kind of towards the end of this, and we might need the last link between you and getting home. So we hope to make this very educational and entertaining and generally lighthearted. Our conversations are very open. This is going to be very different than any talk you've ever been to. This is interactive. We need you to participate in this talk, and questions are very much asked. And so we're going to go through a couple of different things, and we're going to start with a little bit of that interactive idea here. So we're going to get started. If you can take out your phone and point your phone at the QR code. Who is here today? We'd like to know what kind of professional medical providers we have in attendance. So go ahead and click on that. It should bring you up to a quick link with a little one-question survey. And what's really cool about this is we can see this live time as we come through who we got in attendance. If we get some people signing in, thank you very much. You go back now. Fantastic. Well, thank you. And we're going to use this throughout, really a little bit of a knowledge base and kind of make sure you're not falling asleep during our presentation. So again, my name is Brett Gustman. I'm the athletic trainer. I work with the Inova Sports Medicine Concussion Program. And as you can see here is our staff. We have a multidisciplinary approach to this injury. We're going to talk specifically about concussion today, and that is our only focus. Earlier today, we met with somebody and they asked, well, what do you know about occupational health? And the truth is I know nothing about occupational health. I could talk to Dr. London. She gets me involved in what we need to do. But our job, our goal today is really to collaborate and show you what a collaboration and this multidisciplinary approach does for this injury, especially as you look through the lens of occupational health. And so you can see our staff in front of us here. We have our clinical neuropsychologists, Dr. Wambo and Dr. Jennings, who run our program and see all of our patients. So we are run by neuropsychology, not by MDs or DOs. But we do have our primary care sports medicine providers on staff to assist with any kind of therapies or referrals or anything that kind of falls outside of the neuropsychologist range. We have our neuropsychology fellows. Our research team in-house and through the University of Arkansas publishes a significant amount of papers regarding concussion. And our data is looked at as one of the gold standards. And then we have specific physical therapists that work with our patients to deal and manage the challenges that our patients come to see us with that might be outside of the normal range. We're fortunate to have a facility, well, there we go, a facility that's really a top-notch, the most dedicated equipment that you can imagine. And internally, we have 5,000 square feet of indoor turf that we work with our athletes with and our patients on, rehabilitating them through any of the challenges that may come about. So again, we're going to get through a couple of different objectives today. And really, as you can see, I'm not going to sit here and read them, but we're going to go through what a concussion means. The identity and the understanding of this injury has changed a lot over the past 10, 15, 20 years. And for us as medical providers, we need to be able to appreciate how we look at this injury from a healthcare standpoint. But look at the current assessment standards. What should be done about concussion? What should we be doing? Also describing the care that we provide in the concussion specialty clinic. Many of us don't have the fortune of working right in our backyard here at Inova. So how do you take this information back to your area and find somebody that actually can do the things that you need them to do? And then inform when it is appropriate for you as a provider to say, you know what, that relationship that I made with that concussion clinic, now is the time to get that started. And if you happen to live in this area, we're going to tell you how you can send your patients our way. So with that being said, we're going to start with a little bit of a quiz time. Take out your phones, got a couple questions for the quiz there, and we'll see how that goes.
I'm a lot less than right at me, so I'll be standing here. So let me know if there are any users. You might talk. I can talk. Awesome. Okay, let's see. Mic on. There we go. Okay. I'm also a mumbler, so sorry everybody. All right. So you all scanned in on the QR code. Perfect. I think so. So I think step one of understanding this injury is how we diagnose it. And the way that we diagnose this injury is based on these 6 different criteria. What this is from the American College of Rehabilitation Medicine that walks through these guidelines. So there has to be a significant mechanism of injury. It has to be clinical signs, symptoms, information from an acute examination, talk a little bit about imaging findings, and then also, of course, which is with every diagnosis, that it can be better accounted for by confounding factors. So we'll go into each criterion a little bit here. So this is what we use from the American College of Rehabilitation Medicine, but then because we're also a sports medicine clinic, we also allegedly go from the American Federation. It's a little bit slow. Here we go. We also use the most recent Amsterdam guidelines. These are the consensus guidelines for sport-related concussion, or SRC, as you'll see it throughout this talk. And so the guidelines for sport-related concussion is a little bit more vague, a little bit simpler, which basically describes it as a direct blow to the head, neck, or body, resulting in an impulsive force being transmitted to the brain that occurs in sport-related. So that's just something that we look at in our clinic, but what I'll go through specifically is the ACR clinic. Okay. And so this brings us to our first question, this next one, kind of as it relates to criterion 1, the mechanism of injury. So if you want to pull out your phones and pull up the quiz that pops up next. So true or false, a concussion occurs only as a direct blow to the head, as a result of a direct blow to the head. Grab your phone, fill out that quiz. Did the quiz pop up for anybody when you had it on your phone? Yes. We're waiting for some responses, I think.
Set up 5 questions.
Yeah, 5 questions.
Okay.
Anybody need QR code still?
Yes.
Yep.
Okay.
It's a little slow. We'll try it. If we have to move on with the technology, we will.
All right.
There you go.
Maybe the QR code if you want to rescan. Again, this will help you back into to enter the quiz questions. We are on quiz 1, or question 1 currently. Okay, see all the phones mostly are down. Back to where we were. slowly. We don't have many questions embedded throughout, so you don't have to sit with this real long.
Yeah, just keep going. Just keep going.
So you all mentally think of your response to this question, so true or false. Actually, no, we can do a raise of hand. So raise your hand if you think true. A concussion only occurs as the results will go to the head. Raise your hand for false. A concussion. Okay, it's nicely done, T. Look at us learning so much already. All right, so moving through criteria and one that pulls up, a concussion does not have to result as just a direct blow to the head. There can also be the head striking a hard object or surface, something striking the head, but then also too the head moving forward and backwards, not striking the object, it's the mechanism of the concussion. And so what I always like to tell my patients is that not every time you hit your head is a concussion, but also too, not every time you get a concussion is when you hit your victim. And so just something to be mindful of. That mechanism of force enough to initiate a concussion process that occurs. So if you bump your head on the cabinet, so for some people that may be enough force to initiate that response, and for some people that may not be enough force to initiate the response. We actually attended a talk earlier this year that was looking at accelerometer cards, talking about rates of force and T that people experience, and how, if you hit a sledgehammer to the head, that's automatically concussion, not medical. Well, everybody has different individual thresholds to sustain this injury. And so we have to think about it on a more individual basis than that. So again, always be mindful of the mechanism of injury and how people say that this injury occurred, but there are different ways to sustain a concussion, not just by hitting your head on an object. I have another question next. We'll see how this one goes. So we'll just do a raise of hands for this. So true or false, a loss of consciousness is required for the diagnosis of a concussion. Raise your hand for true. Okay, raise your hand for false. Wonderful. The room of brilliant minds, I can see. So part of criterion 2 is just walking through the different pieces that are required for this injury. Nicely done, team. So with concussion, a loss of consciousness is not required. It can be one of the factors that is present for this injury. The loss of consciousness has to occur for less than 30 minutes for it to be considered a concussion. There are different severities of traumatic brain injury. Mild is less than 30 minutes. Anything beyond that is typically viewed as a different type of brain injury. There are other factors that can be related to concussion as well. So post-traumatic amnesia, not remembering events that happened after the injury, that must be within 24 hours. Anything beyond that, again, is a different type of injury. Changes and alterations in mental status, confusion, difficulty following through the step directions, kind of seeming a little bit disoriented, or the presence of seizures, chronic posturing, those are also signs. You need to have one or more of those to be kind of meeting again that criteria, but a loss of consciousness is not. So moving on to the next part, criterion 3 is the presence of symptoms. And so concussion has a lot of different symptoms. It's a very generalized symptom presentation. There's cognitive, physical, sleep, emotional symptoms that can result in this injury. And in isolation, these symptoms can seem like a lot of different things. For example, when you get the flu, what do you feel? You get a headache, you're tired, you feel a little bit nauseous, sometimes you feel dizzy. And those are also symptoms that can be related to concussion as well. And so that's why it's important to think about this mechanism of injury. Is there an acute marker of injury like we just discussed? And then is there the presence or worsening of 2 or more symptoms from these categories? So if someone has a history of headaches before this injury, and then they get hit, if the headache is made worse, that could be part of one of those different diagnostic criteria. And then if we look at criterion 4, once we get there. Okay. The other thing too about the emergence of symptoms is that we typically see the emergence of symptoms within 24 hours after this injury happens. And the reason why we can sometimes see a delay is if there's a different response to the injury, sometimes shock, and that's the presence of symptoms. We see this a lot with a lot of car accidents or injuries that occur with a lot of trauma, such as assault. And so that's why there can be that delay. But typically with this injury, we see symptoms emerge almost immediately. It's not concussion if someone hits their head and then 3 weeks later, multiple months later, there's the presence of symptoms. It just wouldn't be attributed to that injury based on the neurometabolic process that occurs with concussion, which we'll talk about in a little bit here. So always be mindful of when the injury occurred and then when symptoms emerge. Criterion 4 is the presence of positive findings on clinical examinations. Now, in the sports sense, these are kind of your field Sideline assessments, so the SCAT, those are the ones that are really good. The sport concussion assessment tool. For military drill, there is something called the MACE. Now, this is not a tool I personally administer myself. This is something that I was able to find for this talk. But then something that we do administer in our clinic is something called the BOMS, the vestibular and ocular motor screening assessment. So you have your folks, your athletes, your patients do some different ocular motor tasks and then some vestibular tasks. And if that provokes symptoms, that can be a positive thing. The one thing we have our patients do in clinic, this is no task, come out like this, set up your thumb, take your kind of us. If that provokes headache, dizziness, nausea, mental fogginess, that can be the triggers. There's a few different tests that we go through for that. It takes about 5 minutes or so to really talk with this. All right, and then this one's actually one of my favorite criterion to talk about is criterion 5, which is the positive findings on imaging. So for the ACRM guidelines, there is a modifier that can be present. So if there's a presence of a bleed or fracture, that can be still considered a mild traumatic brain injury, just with that factor or that diagnostic indicator of what's probably imaging findings. For sport-related concussion, however, that's becoming fewer presence of findings. And I think what's most important here is that the presence or the use of a CT MRI is not going to find concussion. You cannot diagnose concussion based on the findings of that, because concussion is not a process that can be seen on typical imaging that you can do with VR. Now, there is some research with like DTI, diffuse sensor imaging, that can show concussion, but that's more in the research phase. It's not going to be used clinically or diagnostically. So, with what we usually have available is X-ray, CT, MRI is not going to find concussion. And the reason why for that, here we go, is because concussion is a neurometabolic process. There's no bruising, bleeding, swelling, or like we previously thought with this injury. Basically, when you hit your head hard enough, the cells of your brain rapidly expand, constrict, and then slowly go back to normal. And then that process initiates a neurometabolic cascade, which leads to the immediate onset of symptoms. So like I said, it'd be very atypical for symptoms to emerge much later because that cellular process occurs immediately. And so when that happens is when you either experiences those alterations in mental status or the immediate onset of new symptoms. And so that's what this injury is about. It's more of an imaging crisis in the brain. Your brain is trying to communicate with other cells. It's not able to do that effectively. It's trying to use a lot more energy to do that, but there's not enough energy available. And then that leads to the immediate onset of symptoms that we see. And then the last criteria, here we go, criteria 6, accounting for by other factors. Sometimes with an injury, there can be other injuries that occur as well. We have a car accident. You're in a car accident, you get your seatbelt sign, you up your body. Sometimes having a significant orthopedic injury can lead to people to pass out and make people throw up. So it's always important to be mindful of how the injury occurred, what other injuries you sustained, and also too, just about their own medical history. A lot of what we're seeing in clinic more lately is people who experience syncope or syncopal, and so they have a history of passing out before this injury. Well, they're passed out again, and maybe they hit their head. They're not sure. They already felt dizzy before. They still feel dizzy now. Trying to tease apart is that he's experience with medical history, or is it a result of this injury? So just always something to be mindful of. Is there something that better accounts for the symptoms that this person is experiencing? It's important to be a little bit of an investigator when it comes to this injury. Okay. Let's talk a little bit now about the epidemiology of this injury. And I'm not going to lie to you, it's kind of hard to find some information about this injury in a non-sports, non-military context. So I give a lot of this data with kind of like a little asterisk by it. So what they're calling this in the literature is WRTBI, or work-related traumatic brain injury. Unfortunately, for a lot of the research that's out there, they just group TBIs by all severity, which is really challenging because what we know about mild traumatic brain injury versus severe traumatic brain injury, there's very different outcomes, different experiences, different experiences. So again, take this with a little bit of time. So what we know is that overall work-related injury claims are decreasing, but the proportion of work-related traumatic brain injury claims are increasing. So less people are getting injured on the job, but, or at least they complain about it. There are more people who are highly claims related to traumatic brain injuries. And so there are some different steps of work or sectors of work that can lead to high rates of injury, which is included there. And the picture's a little bit grainy, I'm sorry about that. I try to find a really good one, and the CDC heads up for this for that. What we see and what research has shown is that if you're in the education industry, construction, of course, or EMS, manufacturing, a lot of the more hands-on types of work, you're at a greater risk for sustaining traumatic brain injury. We also see too, or at least in the literature, it shows that most often it's men who experience traumatic brain injury at work. They're often about age 50. One thing that we have noticed more in our clinic, just kind of anecdotally, is we're seeing a lot more of special education teachers coming in with injuries, just because of a lot of the type of students that they work with, who they often get aggressive. And so that's something that we've seen a lot more in our clinic, is people who work in the special education space getting hurt on their job. The one thing that I do have a bone to pick with is, does anyone in here represent OSHA? Yeah.
I don't represent them. I'm the former chief medical officer, and you should log on to the new online data from report 3. For loss of consciousness is in fact one of the reporting criteria. That data system has been up now for the 2nd year.
Oh, interesting. See, and the reason I have a bone to pick with someone who represents OSHA, which I guess is you, you're stuck with that, but I went to their website just to get more information about the percentage of work-related injuries that are traumatic brain injuries. And when I tried to download the data set, it gave me a multi-thousand Excel sheet that I would have to pick through myself to figure out which one is related to head injury and which one is related to other injuries. And I was like, I wish there was just a little bit of an infographic. So if you still work with people at OSHA and you still have that close relationship, I do strongly recommend an infographic on the breakdown of injury types so that I didn't have to do a little bit more work. So that's my bone to pick with OSHA. Let's talk a little bit more though about kind of different types of athletes that we see or different types of occupations that we see in our clinic. And I think one kind of easy group to think about is the tactical athletes. Just again, one of the sports medicine program, we see all types of injuries, but thinking about the tactical athlete is really what we're here. And tactical athlete is someone like firefighter, EMS, police officer, a lot of people who are on the job and doing a lot of heavy lifting as part of their work. Who just have inherently a little bit more risk. So the data that I have is related to firefighters, who once the primary shifts over. There we go. Oh, a little bit too far. And so the first report is from 2018 to 2022, just kind of broke down the different injuries and different injuries there. The different injury breakdown, there we go, that happened. Concussion is not something that they were collecting data on in this injury report in 2018 to 2022. They diagnosed, or they had a category for head. They didn't say what that was, just head. And then they also looked at 2 different, where they got hurt, either on the fireground or where they sustained the injury on their body. And so we were hoping, okay, maybe 2023, we're learning more about this injury, people are getting more excited about it, maybe we'll have more there. Concussion also not listed there as well. So concussion is not something that's even being well tracked by national data standards. So it's really difficult to get a lot of information about this injury. And so what they did break down though is kind of looking at fireground versus non-fireground injuries. Majority of the injuries that occur in our tactical athletes occur off the fireground. So either responding to an accident or an emergency, leaving the scene of an emergency, or being at the facility itself. But less often does it happen on scene. But they do happen on scene. But when they do happen on scene, they don't categorize or identify concussion as one of the types of injury that we see. What we do notice, though, is that there's a pretty high rate, once it switches over, of motor vehicle accidents related to these tactical athletes, these emergency medical responders, which I think makes a ton of sense if you think about it. There's a pretty high risk if you're going at a high rate of speed, you're going to get traffic. I mean, just the traffic here in Virginia. I'm from Michigan, and I've never dealt with something like this before. And so when you're weaving and bobbing through people who really don't care if you get there safe or not, the same thing happens with our firefighters that we see. Two other types of emergency responders. There's a really high rate of motor vehicle accidents, which what we talked about, can be a significant mechanism of injury for concussion. And then there's also rates of injury with firefighters in a personal use, either getting to work or leaving work. So something that maybe we could parse out as related to injury, but nothing again definitively where they say, yes, this is how we track concussion in firefighters. So moving on to the next part, once it finally switches over, let's talk a little bit about recovery trajectories. And I think I do have some questions here, so we'll have to do either raise of hands or hopefully the thing works back. If not, that's okay. So what we used to think with this injury is that someone would have a mild concussion, a moderate concussion, or a severe concussion.
But that's actually not the labeling that we use anymore. It's also very confusing because, like I said earlier, there's a mild traumatic brain injury, moderate traumatic brain injury, and severe traumatic brain injury. So to have those different labels, concussion related severity labels, it was a little confusing for patients with expectations for recovery. We would search severe concussion. We got the literature about severe TBI, which is a different type of injury. And so the way that we look at concussion now is through a profile model. And the way that this works is that concussion can have different symptom types or different symptom presentations. And Dr. Courtwright will go a little bit into this when she does the piece presentation. But what we see is that there's typically 5 profiles: anxiety, mood, post-traumatic migraine, ocular, cognitive fatigue, and then also vestibular. And then there are 2 modifiers, which for some reason did not show up here, which are sleep and cervical. And the idea is that these symptoms can influence each other. So if you sleep poorly, you're less likely to be able to think clearly the next day. You may have a higher mood or feel not like yourself. And if you don't feel like yourself, it's hard to fall asleep at night. You can kind of see how the pattern starts to circle like this. And so what we do is we treat this injury based on the different symptom presentation that they have. There's a lot of research behind this, which you'll see on the next slide. There we go. There are a few different profiles model approaches. What we use is the concussion clinical profiles model approach to treat this injury in our clinic with pretty high rates of success, if I do say so myself. And so thinking about this injury, though, a lot of questions that we get either on the phone when people are scheduling, first day in clinic when they come in to see us is, how long am I going to be dealing with this? And what we know from research, and again, a lot of research on concussion is done in sport and military, just because that's where a lot of the funding is that recovery can take anywhere between 7 to 28 days, typically, 7 to 28 days, which I think for some people seems longer than they expect, and for other people seems a lot shorter than they expect. And so I kind of want you to sit with how you think and how you interpret this data. So what we see typically is that people start to feel better within that time range. Sometimes the symptoms that can linger a little bit longer are the cognitive symptoms, feel like a little brain foggy, hard to remember, feel a little bit slower. The data shows that those also recover within a 28-day time frame. So what we typically see in clinic is that people come in, their physical symptoms start to get better, so their headache and dizziness. Then emotionally they start to feel better because they don't feel gross and just doing normal activities. And then cognitively they start to feel better as well. Now when we look at this in a WR-TBI or work-related TBI, again, there's just not a lot of great data out there. It's not as clearly defined as it is in sports space. Again, I think because research is still expanding, we're still learning appropriate methodologies for this. And I found a lot of mixed results. Some were saying, okay, typically by 6 weeks, most people are back at work. Then there was another study that said, by about 6 months, most people are back at work. And then there's another study that was like, well, it was 12 months. Some people were still out of work and still having symptoms. So it really varies here. I think anecdotally in clinic, what we see is it takes anywhere between about 1 to 3 months for this injury. And one of the factors that can lead to a prolonged recovery is the longer time it takes for you to see a specialist, get quality care. And so because of delays in authorizations, we typically see these patients get to us a little bit later. They're usually at the 1 month mark of recovery by the time they get to come to the outside. So that could account for a little bit of the longer recovery times. But there are some different pre-injury risk factors that happen like this. And so this is a question, again, a little true and false. We can do a hand raise for this if we want to. So everyone is at the same risk for experiencing prolonged recovery from a concussion and overall recovery time. Raise your hand for true. Raise your hand for false. Thanks. Again, we're really smart people here. I agree. There are different risk factors, pre-injury and post-injury, that can affect how you recover from this injury. One thing that I really want to point out, and again, this is in athletes, but I think if we think about our tactical athletes, this still applies. If you continue to play after sustaining an injury, after experiencing symptoms, you are at a greater risk for experiencing a prolonged recovery. Even if you play for just 5 more minutes, 10 more minutes, stay on the scene for a little bit longer, run into this space, you are at a greater risk for a prolonged recovery. So what a lot we see with our athletes is we try and tell them, it's not worth playing for 5 more minutes, miss the rest of your season. Same thing when we think about our folks who do, our tactical athletes as well. Now, that's more life-saving kind of factors. You can't always pull someone off the fireground. You can't always pull someone off the space that they're at. Which, again, is something to be mindful of. If you experience an injury on the job and you continue to work, you need to get a great risk for long. Some other factors that we look at for this injury, there are pre-injury risk factors. Unfortunately, women, we get the worst end of most things. If your female sex isn't indicated for prolonged recovery, you have a history of migraines, either personal or family, history of ADHD or a learning disability. These are all things that can predispose you to having a longer recovery time from this injury. But there are also some post-injury risk factors as well that can prolong your recovery time. Like I just mentioned, continuing to play. But also too, if you experience a post-traumatic migraine, that can be something that indicates a longer recovery time, immediate onset of dizziness, mental fogginess, and then also too the presence of motion sickness afterwards. These are all things that we kind of look at to see if we can expect where and how someone will recover from this injury. I do think it's important to note what I didn't say is an indicator of prolonged recovery time when they pop up. But loss of consciousness is not an indicator for prolonged recovery time. If you're within that 30 minutes, you're not at a greater risk for longer recovery. Also, too, the presence of posturing or fencing after this injury is not an indicator of a prolonged recovery time either. So there's this belief that if an injury looks worse or more intense, it must take longer to recover. Research shows that's actually not true. So something to look for when you think of this injury. Right. And when we think about getting here, there we go. I did find a little bit of research on work-related TBI and some factors that can indicate a prolonged recovery, the presence of insomnia after the injury, if there's any head or neck pain, and I think they mean that in the more physical sense of like outer head pain or actual neck pain, it can prolong your recovery. I think to no one's surprise, the diagnosis of hospital-acquired lingering pain makes it prolong experiences of symptoms. And then also too, the type of injury that occurred and the presence of symptoms that emerge afterwards. So if injury occurs by assault, we often see that that can be a longer recovery time. And also too, with that, the diagnosis of PTSD. There's a heightened nervous system response to this injury when we see it happen in ways where you can't expect. When we see athletes, you know that when you step onto the field, you're at risk of getting an injury. But if you're leaving a scene of an accident, you're driving away, you're at work, you're working with a child, and they hit you unexpectedly, someone rear-ends you, that's something that your body wasn't braced for, wasn't expecting. There's that kind of nervous system response, and it can take a little bit longer to recover from this injury. The other thing too is something that I love to talk about with everybody and all of my athletes, but also too practicing this in my everyday life, is something called the cycle of avoidance. And this is where we see a lot of symptoms tend to prolong and to limit and stick around. So the cycle of avoidance can happen not on a very large scale, but also on a very small scale. So today, on my way to this conference, I was trying to practice my slides, but instead I scrolled on Instagram because I was a little bit nervous, so I didn't want to practice yet. That's actually a small scale to practice the cycle of avoidance in a backup. Instead of practicing my slides, I did a task that made me feel good, but the slide practicing was still there. I needed still to prepare. I just delayed the amount of time that I did it. And then when you come back to it, you notice, oh, man, I feel a little bit more anxious than before. And then sometimes you go back to Instagram, sometimes you start your task. We do this every day too with charting. How many of you put off charting a nail because you want to do something else because you've had to wait a little bit or because you're tired? The note's still there. Now you're just more tired, more time has passed, nothing has changed. Pain is a really significant contributor to the cycle of avoidance. And we are hardwired to avoid discomfort, both on the physical level, the emotional level, kind of everything. And so when we do something and we get a headache, or we do something and we get dizzy, your brain and your body learn that that's an unsafe activity. And so it wants you to get smaller, shrink, and do less. What we find, though, is then people start to live in a very small, shrunken, and less world where they can't do anything. They're wearing sunglasses inside because it's too bright, so they keep wearing them inside. Noises are too loud, so they keep turning them down. Eventually, all you have left is a dark, quiet room where you sit and you think about all of your symptoms, which is not a great way to recover from this injury. We'll talk a little bit more about what that should look like. So what we try and have our patients do, through a lot of coaching and a lot of encouragement, is to avoid the cycle of avoidance. So by doing small things, you gradually learn that this isn't so bad, this is a safe activity for me to do, and then symptoms become less intensive. So something to keep in mind when you put that chart note off for a little bit, or you check your email instead of doing your work, it's a cycle of avoidance in practice. But it happens even more intensely when it comes to pain. And then kind of the last thing that I'll leave you all with before we do our hockey switch back to Brett is that with this injury, it's important to set your patients up for success. You will, and you do, see patients get better from this injury. This is a recoverable and treatable injury once my slide switch is over. If you set that up at the first appointment, then people will know what to expect about their recovery. I love my job, and I mean this so sincerely, because I see people get better. I can see someone come in clinic, and they're crying in front of me because everything just feels like their life is turned upside down. And then a month later, I can see them going back to living their everyday life. sometimes even feeling a little bit better than they did before. It's rare, but it always feels really good when it happens. So setting up your patients for success that this is a recoverable and treatable injury can help to reduce the amount of recovery time they have.
I think
Setting
it's
the
okay.
expectation of the
Yeah,
providers.
it's just really slow.
We'll talk a little bit now to do our happy shift to seeing how we can recover from this injury appropriately and what new information I will talk to you next week. So I'm going to switch it back over to Brett.
We don't have to hit that quiz button. We're just going to do it live. The internet is failing us as it always tries to kind of do, right? But just like in life and in medicine, we got to pivot and prepare. So we're just going to move forward here. The question that I wanted to ask, as you can see on the board, is what do you think right now, before we go into this, how do we handle this injury? Dr. Hill did a great job of talking about what this injury is and how we should be appreciating the effects of it. But we're going to start talking about how we treat this. What do we do for our patients? So right now in front of us, right, current research on concussion recovery emphasizes the need for increased rest, right, which means limiting computer screens, napping, avoiding physical activity, and reducing social activities. How many people feel that that is the way that they approach this injury right now? Increased rest versus their normal approach. Come on, let's be truthful. It's okay. That's what we're here for, right? And how many people are encouraging patients to return to their regular activities, let's say within 3 days? 3 days. Okay, cool. That's a good starting point, right? And, we talk about correlation, and we're going to talk about science a little bit, but I want you to, as scientific minds, appreciate the next few slides of correlation and what that word really means. Anheuser-Busch's stock compared to the distance between Jupiter and Venus, correlates. Milk consumption and the rate of divorce in Colorado correlates. And my favorite, of course, Google searches. Oh, let's go back. No, we don't want to miss that one. Google searches for why people don't call it 1D1 versus 11, and the number of tax collectors in New Mexico. So I always say this in clinic, I love science, but what is science really telling us and where does it lead us? And how much do you have to appreciate what you're reading? And what we know about concussion has changed dramatically over the past 20 years. What you have in front of you is a slide of how much concussion research is published through PubMed, and you can see the green is consistent on both charts. There's just so many, we split it up. But you can see in the other areas, concussion and brain head, concussion in sports, concussion and reliability, those have significantly increased and are projected to even double and triple their rates over the next 5 to 10 years. There is a significant ton of money because our most important asset in this country, the NFL, puts a lot of money into concussion management. And so we're seeing a significant increase in understanding and knowledge of this injury. And here is very good. And so because of that, the most up-to-date research and what we see is what you might have heard about is the consensus statement. And consensus statement is put out by a large group of providers that get together every 4 to 6 years. And their last group was in 2022. I apologize, the computer is going nuts on us here. And what that census statement basically said, it brought up 4 different subjects that we should base our new treatment on, and this should be updated soon, but I'm going backwards here to see if it works. The first is, as we've discussed and Dr. Hill talked about a little bit, is the idea that we should not be prescribing strict rest. Strict rest is a terrible way to treat this injury, even in the first 24 to 48 hours. You should be encouraging your patients, especially within the first 24 to 48 hours, to engage in regular activities, and we're going to talk about that, okay? The best idea of cognitive exertion, that means using computer screens and thinking, is you do not have to avoid them. Maybe for the first day or so, but you should not be completely avoiding them. Return to sports, return to activity should be going on in parallel with return to work and return to thinking activities. And again, we're going to talk about this in just a few moments, but the idea of engaging in regular lifestyle activities in the first 24 to 48 hours is actually very encouraged. As a provider, what documents or what testing can you use? And so they put forth the SCAT and SCOPE 6. It used to be the SCAT and SCOPE 5, so we're getting there. SCAT and SCOPE 6. SCAT is used if you are working in an emergency situation. Maybe you're covering a local high school team, or you see somebody within the first 72 hours of a building collapse or something from that perspective, you would use the SCAT. The scope is for beyond 72 hours and up to 30 days, and that is a little bit more in depth. It has a couple of different pieces in it. Let's see if this clicks ahead that go through the assessment process. And then it's not going to work, but that includes everything from a vestibular and ocular motor screening, as Dr. Hill talks about, balance testing, cognitive testing, physical activity and motion, and putting all these pieces together to ensure a comprehensive assessment. You know, one of the big challenges we have with this injury is that there's not a lot of time given to, oh, I just hit my head, right? And oh, I just hit my head really still warrants the need for a thorough assessment, because the problem with all these old injuries and all this bad data that we always hear about these people that have these prolonged issues and challenges is sometimes they didn't take that initial injury seriously enough to get an appropriate evaluation, and that can lead to significant issues down the road. Thankfully, our slideshow is catching up and going way past what we wanted to. But the idea is, by using this scope or the guidelines from this scope to create a comprehensive assessment, what we do is in turn is we create a plan. We create a treatment plan. Concussion is treatable. And by making a roadmap, by making a treatment plan, number one, you tell your patient, hey, I got a plan, this is how we're going to treat this. The light bulb goes off in their head and they feel like that they're going to get somewhere. When you tell somebody, hey, I don't know, see you in 2 weeks, good luck, hopefully you feel better, how do you think they leave your office feeling? So having a plan for starters really changes the outlook, and Dr. Hill discussed this, right? Being able to reassure patients that you know what you're doing, whether you do or don't, is a really good way to help them feel better leaving your office. And so starting by creating a plan is going to be an important part. So by using that thorough assessment, by appreciating the profiles as opposed to mild, moderate, or severe, we're going to create this outlook plan of how we're going to treat it. Are we going to apply behavioral reg? Are we going to give them, sorry, I'm not good at pictures. Are we gonna do some behavioral activations? Are there any specific therapies or treatments that are needed to help accelerate this recovery? Remember, at the end of the day, whether you break your arm, smash your head, or anything in between, the only thing that we're doing as medical providers is creating the optimal healing environment. Guy breaks his arm, we put him in a cast, that's the fastest way to get better. Cast isn't good enough, we need surgery, put a rod in there. We know now that's the fastest way to get better. We create the optimal healing environment. And when we look at concussion, there is an optimal healing environment. I'm on computer. This is the best part. Right. So, when we talk about recovery from concussion, many of us have thought about rest. And rest was awesome, right? We're of the crowd, not these guys up front, we're of the crowd. Well, you were home sick and it was 11 o'clock on CBS. What did you watch? Come on, nobody? The price is right, there we go. Come on down. It's not funny. Like the music is going, everything. Bob Barker, come on down. You win. You win last contestant, right? Don't forget to spend a new to your cats and dogs. But the truth is, what we know is those were great times. Mom brought us tea and toast and everything like that. But what I'm about to tell you, what we're about to go through is to understand that rest is the absolute worst way to treat this injury. Rest is a problem. What we know about rest is the word itself is very misunderstood. Rest often leads towards avoidance, as Dr. Hill talked about. Rest leads towards, if you give them an inch, they're going to take a mile. And you said rest, so I spent the last 3 weeks in a dark room. I haven't seen a thing. And let me ask you, unless it's intentional, if I took you and put you in a dark room for 5 days, do you think you would be light sensitive on the other side? Right? If you lived in Northern Virginia, do you think you would tolerate the people in the world around you 5 days of being away from them? Right? Think about those vacation days when you go away and you come back. Right? And I'm from New Jersey to talk about the driving, right? This is still the worst place in the world. But really, honestly, many people take it to the extreme. They take just a little bit of the idea and they bring it to the absolute utmost worst of it. So what we know is that telling them to rest is not a good way to manage this injury in any bit. So we're going to focus on two specific areas. My computer doesn't want me to do it. And one is behavioral regulation. And this is the basics. This is what your grandma used to say. We used to call this the grandma talk. Okay? We're going to get through the treatments. And so this is the fork in the road. This is more so than sit at home and do nothing. You got to get up. You got to get going. You got to get your life back. And so behavioral regulation starts with the basics: sleep, nutrition, hydration, and stress management. For sleep, we do not encourage our patients to take naps. We want you on a regular schedule. Now, Regular in Northern Virginia is usually somewhere between 3 and 5 hours, right? That's not good. We want to focus on 7 to 9 hours of sleep. And I know that's beyond most people's goals, but really consistency is the key here. So a regular bedtime, a regular wake time, and being as close to that 7 to 9 hours as possible. Nutrition and hydration, and I can speak for all of us saying that my breakfast this morning was a cup of coffee. Thank God there's a really good donut shop downstairs if you need on the way out. They're open until 5. But for many of us, we do not do a good job of eating breakfast in the morning, and that's just going to really offset our day. And we see that a lot with our workers and with our athletes and with people on the go. They're often relying just on a cup of coffee to have breakfast, and that's not going to do it. Hydration is a big factor across sports, across cognitive performance, across physical performance, right? Remember, we're creating the optimal healing environment. We're taking away these basics of sleep, nutrition, hydration. There's no way we're going to fuel this body. There's no way we're going to fuel this brain into recovering from this injury. And last, as we talked about, and we're going to talk about, because I really feel that this is a significant portion of this injury, stress management. And this is where you as the provider come in significantly to help quell this at the first visit. The more that you can put confidence into the outcome of this injury, the less stress there's going to be along the way. Second to this is really getting going. Behavioral activation is going to take a while for it to come up because it doesn't really work, but we do not avoid activations. After that, especially that first 24-hour period, we want people getting back into activity, physical activity, cognitive activities, social activities, and ocular activities. That means using the computer screen, meeting friends for lunch, going out to maybe go for a walk. Everybody with a concussion can walk, unless you broke your leg too, then you can't. But everybody with a concussion walks, so we want them moving, okay? We do not avoid the things. Now, if they feel better, we want them doing more. We're not going to limit somebody that feels well into doing more. I'm trying to help you, like today out on the marathon, we're talking about the sweeper truck, right? Like, you do not want to see the sweeper truck. That means your day is over. And so what we're talking about here is the bottom. If people want to do more and more, go ahead. We're talking about keeping the people at the backside going. We cannot let people sit still. We cannot let people just rest through this injury. And so,
yes, sir. That includes football players too.
That includes football players, absolutely. I mean,
so my quarterback should be playing.
Well, we talk about this, absolutely. We talk about this in a non-contact level of participation.
Quarterback.
The Shannon's quarterback. You give me
quarterback. Yeah. No, I'm trying to make that.
Yeah. Well, I thought they were talking about my team, the Jets, calling him to come play today. But we're going to do this, and through everything that we do, whether it's non-contact physical activity, yes, as we talked about, work using the computer, we go with what we call expose and recover. We do some, we take a break, and then we do some more. Here's the trick: we can't do everything, crash out, and then have no energy left for the rest of the day. We have to do what we call, like I said, expose and recover. For all of us that have lifted weights before, this is the example I give in clinic, right? You can't walk by the room every day and say, tomorrow, man, I got this. I got this tomorrow. You're not going to get any better, right? And you can't go in there every day and just PR like you're on YouTube and people are watching, throw up your best weights all the time. You're going to be so sore you're going to break something. But the trick is, the secret to it is going in there and getting sore. And the soreness where when nobody's looking, you stand in the mirror, you give yourself that flex, and you're kind of, you feel really good about yourself. And it's good to come back the other way. For those of us that play golf, and I play golf, usually we're not in the weight room, so it's like hitting the birdie on the 18th after you've bogeyed the past 17, right? It's money in the bank, you're coming back again. But the idea is expose and recover because we want to manage our day and not avoid it. So we talk about increasing by 2 points and taking a break on a 10-point scale, or hitting 5 out of 10. Everybody adapts to this in a different way. There are some of us that do not stop talking. And for those of us, what we usually do is use a timer or something and say, stop it, and take a break every 70 to 90 minutes. It's an easy way to go about it. But the idea is, through the day, you have to take people like me and shut us down somehow, so we can recover with short stimulus breaks. It's not really rest, it's a stimulus timeout. So this is 10 minutes of sitting in the corner, no cell phone, no computer, just close your eyes, 10 minutes of recover, and then return back to your activity. So we talked about this a little bit, but just some idea of how important nutrition is, and it's beyond 3 meals. You know, the way that our body cycles, we do know this, but you know, the proteins and the carbs, they are gone after 2 or 3 hours. So the truthful way of doing this is multiple small meals throughout the day help us fuel the body. Remember, optimal healing environment. People often ask, what should I eat? We have a hard enough time with just eating anything, and so getting those meals in for starters is the first thing. And of course, the healthier you eat, the healthier you're going to feel. So adapting those meals to that, but trying to fill our plates throughout the day is actually a very important part of the recovery process. We talked on hydration as well. I've got a little statistic on the right here, shows you, especially in sports, just kidding, especially in sports, that how much hydration affects cognitive and physical abilities. When you're 1.5%, 2% dehydrated, I promise it said it up there, your physical abilities get really distorted. And so Gatorade did a study, I think it was in 2012, I apologize, it's not on the slide, just kind of popped in my head. And they looked at college free throw shooters. These guys are 85, 90%, they're just banging out all day. They don't miss, right? And they watched them as they went through practice and got them to run a little bit and got dehydrated. And once they hit that about 2.5% dehydration level, they were all of a sudden like 55, 60% free throw shooters. They couldn't hit the side of a barn, right? And so we know really from research, Madeline's taking over, we know that the goal is, I must not be that good, I'm sorry, Madeline, but we know that the goal is the guy that wins the game in the fourth quarter, that out-rebounds the other player, that wins the ball in the corner, is probably the guy that drank more water during the week than it is the guy that actually practiced harder. And that's kind of a weird concept, but it's truthful. Our bodies are machines, and we have to fuel that machine, and hydration is big. I talked about sleep. I'm going to go with that slideshow here. I've done this a couple of times. I talked about sleep, and so again, sleep is important, 7 to 9 hours. There is so much research to support the idea that lack of sleep, decreased sleep overall, is really going to create deficits in cognitive and physical abilities. And I think we all know that, right? Like any day you had 3 or 4 hours sleep, you are not doing well. You're not processing well. You're not answering well. By 4 or 5 o'clock in the afternoon, you're driving home going to Northern Virginia, and then somebody's coming in your eyes, and all you want to do is take a nap, but you can't do that. But the idea is sleep can really throw us off, and we can have a big problem from that. So again, maintaining sleep across the board is going to be a big factor in all of it. We lost more in the slideshow, guys. We're trying to do so hard. Okay, so we're going to talk about returning to work, and I think that's really the next section. I'm kind of doing it on the computer here. You know, what the research kind of tells us is that return to work should happen within 2 days, and we discussed this earlier. But when we look at some of the research that has happened out there, what we know is that those patients that do not return to work within 2 days actually are likely to be out at month 2. That's 2 days. Because they need to go back and finish that. That's really big. And those patients are not back within the first 4 weeks, at least 6 months. It's a lot. What happens is we get multiple aspects of challenge, right? No matter how much we want to believe that everybody loves their work as Dr. Hill does, that a lot of us don't like what we do. And this is the first way to not go back to work. My head hurts. Says me. Oh, okay. Keep saying my head hurts. I'm not saying about this. What we need to do as medical providers is take all this information that we spoke about today, awesome. Take all this information we spoke about today and really kind of create this plan of how we're going to go about it. I might have jumped around a little bit. I think I skipped stuff. And so, we need to get our employers to understand that their employees need to be there. And if that means in light duty roles or limited action roles, or just as an observer, right? We need to take into account for whatever environment they work in. As the example, we're not going to put the football player back into a football game. We're not going to put the captain of the fire squad in charge of 28 other people's lives in making life decisions in that period, but they can certainly be part of that, right? They can certainly be have a role in that process. In the football players, it's non-contact. In the captain's role, maybe it's more administrative. And so again, the idea is we need to return athletes back to the field in a non-contact way. We need to return our employees back to a role in their employer's scenario in a non-contact, or in this case, in a light duty role, administrative, using breaks, and kind of working with both sides of that. As the medical provider, they're looking to you to work there and say, what can we do, right? And so, they can do a lot. They need to do a lot. Again, that's what we're leaving here today, understanding is the less we do, the harder it is to do. So set expectations, provide realistic timelines for recovery. Dr. Hill talked about this a little bit, 3 to 4 weeks, 6 to 8 weeks in a work environment, that's for full recovery, 6 to 8 weeks. If it's taking longer than that, there's likely some outside source going on. Whether it's truly something like a vestibular or an ocular motor issue that you can work with regards to an assessment, or likely some sort of stressor or other factor limiting the role to recovery, those factors are going to come into all of this. And we passed through it, and Dr. Hill is trying to do the best to keep up with me, and I'm jumping around like a rabbit here. But we talked about this a little bit, and we emphasize it, is that acute stress response. And as medical providers, I think we don't appreciate that for some, whatever reason, whether you're a dermatologist or you're a neurosurgeon, the person walking into your room is not right. And that's why they are there to see you, the medical provider. And that is, for whatever level it is, for that individual, is a stress response. There is something wrong with them, and they're coming to seek help from you. And I think as a medical provider, at all different kind of stages and stuff, I think we don't sometimes appreciate that. And it's important to, because the patients that are coming to see you with regards to concussion, the thing that helps them understand how to manage stress and how to alleviate it and cope and talk and all that, that's the thing that's messed up. And so that whole system of appreciating what's going on and being able to manage these issues, that fight or flight, that parasympathetic system is often compromised during concussion, and they are running on adrenaline. They are full speed and burning themselves out and running themselves into the ground. And they go to the internet. Yes.
On return to work, different for children and adults who have documented.
That's a good question. Let me hold that thought and then we bring it back around to that. When we have these patients and they're not doing these things, they create bigger issues with regards to stress. And so by putting them into this regular environment, managing it, knowing that they're still in touch with reality, that hopefully reduces that. Now, when we talk about recurrent concussions and the idea of whether that is a factor in the recovery process or in the return to work, return to learn process, I think the bigger factor with recurrent concussions is oftentimes is the misunderstanding of the injury itself. And this is a problem even from initial injuries. How the old injury was managed can significantly play a factor in how this injury is managed. As we hear today, we're talking about a very different approach to how we treat this injury. And if the other injury was treated with a significant amount of rest or restrictions, the idea of changing course and then re-engaging as we're talking about today can be a big factor, because as we've all been to, if you have a trusted doctor that you go to, they tell you one way, and then you go to another doctor, now you have confounding doctors, and it can be difficult from that perspective. Truthfully, from an absolute concussion standpoint, we see no research to support that history of concussions leads towards further concussion. We stand on that with the idea that the way that we treat it, if you said I had a concussion in the 80s playing football in Western PA, probably different than a concussion today on the sidelines, right? The way that we treated these things. And you talk about long-term issues, and we're going to table that for right now, but these are many different factors that go into how we can appreciate concussion itself, right? I think there's a vast shift in the understanding and knowledge of this injury as you hear through how we're talking about treating it, and that in effect has a big factor for those of us that may have been part of the old world and the new world, right? And that is a line that we're getting over. And that is a line in the sand with regards to research too, and how we look at this. So what we look at it is, and we'll come back to it, the idea of what does full recovery from concussion mean? That's significantly different than 10 years ago where it was 2, right? 2, yep, 2 are good. Okay, back in the game, So we've changed that approach a lot. Gianna, yes, sir. Question. Yeah, okay, we're almost there. So there, that's good. So we'll talk about when do we say somebody is cleared from concussion? When do we know that everything that we can do from an understanding and knowledge point of this injury that has recovered back to normal? And these are some of the factors that we look at. They have to be symptom-free. And symptom-free is a relative term. If, as Dr. Hill talked about, you were somebody that managed 3 to 5 headaches a week, that's symptom-free for us. It's back to your 3 to 5 headaches a week. I mean, I wish we could be, Harry Potter and cure everything, but we're not that good. So symptom-free, back to your baseline at rest, with physical activity. We want you to be physically active and doing what you normally do before we're going to clear you. And then with work and your school environments, you're using the computer or other cognitive tasks that you have to complete. We have certain measurements that we use during cognitive testing, as we'll discuss a little bit, vestibular and ocular motor screening, and we do mood assessments in everybody because, as you've seen today, we take a significant factor into how much mood can relate to this injury. And again, we want to know that you can do as much of your non-contact physical activity as you used to do. We're not going to take you and turn you into a marathon runner out here next year, but the idea is if you usually go to the gym 3 times a week and not have any symptoms from it, we need to have you back to that level of return before we say that you're symptom free. We don't want to kind of leave you hanging out there. I don't know if you could bring up the sports slide. Is that possible for what's next? Well, okay.
This one?
Bummer. Okay, so maybe just yeah, there we go. All right, so I really made it small just to make sure any optometrists, please, they get a good buck on the way out the door. But if you can see it here, it's hard really. You know, we don't really like to use rubrics, but these are suggestive ideas based on how you feel what mild, moderate, maximal exertion mean. And we want our patients, we want our athletes, we want our tactical athletes, our firefighters, our police, EMS, workers in factories that are doing a lot of physical labor to be going through these activities up through that line before we clear them, right? We want to know that they can lift heavy and twist and spin and do all that kind of stuff to remain symptom free, because if they can't, we need to treat it, going back to what we talked about earlier. All right, going forward here. And then last is prevention. Yeah, keep going, one more. Baseline testing. We'll talk about this for a second. I know this is a huge topic, Dr. Long. Really wanted me to emphasize this. So this term is thrown around a lot, especially if you're familiar with sports. And this is perfect. When you're familiar with sports, you might have heard about baseline testing. And we talk about neurocognitive testing post-injury. So what is this? So from a baseline perspective, the test is the same both before and after injury. A baseline happens before an injury ever occurs. It's typically referred to as a computerized test that looks at 4 different areas. It's not a concussion test. And it's very, very helpful when we look at patients that may have previous histories of learning disabilities or even be gifted or talented students, because we have normative data, but everybody appreciates normative data for being normal. And I'll be the first to tell you if you haven't figured it out, not a lot of people are normal starting with me, right? So the idea is having a baseline can assess how well that individual performs on those 4 specific areas of cognitive testing. And should an injury occur, we use that exact same test with different stimulus to be able to assess if there are any cognitive deficits compared to before the injury. And this importance is significant. What we know is that cognitive deficits can exist beyond somatic symptoms, meaning your headache can resolve, but you can still be really hurt or making critical decisions. And that may exist beyond the time that those symptoms occur. And so without using some sort of cognitive testing to assess for these injuries, we may be missing one of those critical pieces of complete recovery. By asking somebody, do you remember what I asked you last week? And they say yes, we say that's a good answer. Okay, that's not enough. And so again, this is where kind of looking towards that specialty clinic, if you don't have this in office, is bringing into these extra special pieces of assessment. The other side of this is the bombs. Dr. Hill talked about it a little bit. The brief 5-minute assessment that can be done as part of baseline as well as post-injury, and absolutely should be done. You know, when we don't assess for vestibular ocular motor deficits during syndrome, we're missing 40 to 60% of concussion challenges. And that profile in itself, again, saying the same thing, being redundant, that is very treatable. With a skilled therapist, a vestibular and ocular issue should be recovered within 3 to 4 weeks. We're not talking about peripheral, we're not talking about BPPV or vertigo, that's something else. Now, in our scenario, where we live, that might be more likely, believe it or not, than in a sports scenario. We're talking about heavy machinery, large pieces of equipment, and large heights and things like that. And so when you have those and you hear those symptoms of possible BPPV, then you have to treat that separately. But from a concussion dizziness standpoint, somebody that feels slow and wavy and just kind of the room is just discombobulated around them, that is actually treatable. And the worst thing you can do for that is rest, right? The longer you avoid that, the more sensitive it's going to get, and that sensitivity is going to build, right? And that's going to go bigger and bigger, then you're not going to be able to move. So we have to be very aggressive with dizziness in the appropriate stance. Hit me up one more time there. Like pretty severe. So we talk about prevention, right? And honestly, if you couldn't tell, we've been doing this slideshow very similar to this since like 2000, so I don't know, 10, 11, 12. And this slide has been in there for, I don't know, maybe 15 years now, whatever it might be. And if you watch football, Green Bay Packers, Romeo Dobbs, hit me up, right? This is the real thing now. Like, that's what the guys on the field looking like. So, yeah. I thought that was kind of funny. That might be slightly inflated. But the idea is, from a prevention standpoint, helmets and helmet safety, and there's a lot of gadgets and gizmos and doodahs out there, and we can have a whole other conference, not just a lecture, conference on all that stuff. But there's some very good information for you to pass on to employers, to employees, when they say, what should I be wearing on this noggin toboggan? Well, the Virginia Tech website that studies football helmets actually also studies construction helmets. And they give non-biased data beyond NOC and beyond OSHA, and they look at different things like rotational forces, and they look at different factors, and they do not account for price. So the less expensive helmets might be more useful than the more expensive helmets. They're going to tell you when it's garbage, and they're going to tell you when it's good. It's a non-biased site, very easy to read, 5-star reviews, very well accepted across the sports environment, and it's looked at for football and baseball. But just looking on there, that's the instruction. I think that's it. We're not going to take the quiz. Dr. Courtwright is going to just kind of pop up here, do a little hockey shift, and we'll take questions at the end.
All right, so I'm going to take this entire model that Brett and Dr. Hill have talked about and put it into practice with a small case study. We'll be exploring the injury of a supervisory police officer who's involved in a motor vehicle accident. As Dr. Hill mentioned, EMS providers are actually at an increased risk of concussions with motor vehicle accidents, whether responding to or leaving scenes, and that's what happened with this police officer. He had his lights and sirens on, he was headed to a scene, and as has been alluded to, if you've experienced Northern Virginia drivers, it's impressive there's not more motor vehicle accidents than there already are. And so he was hit, T-boned on the front passenger side. His vehicle his police cruiser had full airbag deployment, and he had a linear acceleration of his head, so his head went forward and back. It probably also went side to side, a little bit of rotational positions given the way his cruiser was impacted. But he did note that he hit his head on the steering wheel upon impact. And so when we look at the acute injury markers that we all learned about earlier, he did not have a loss of consciousness. He also did not have any post-traumatic amnesia, but he did have some confusion and disorientation right away. So very confused about what had happened, where he was, what was going on, kind of the next steps, what he needed to do. He also reported his immediate symptom was shock. We learned that, especially with motor vehicle accidents, that's pretty much the primary symptom. Something very sudden happened, you weren't expecting it. People just feel like they're in shock. They don't necessarily notice any immediate symptoms or any other like physical symptoms right away, especially if they have someone else in the car or if we're thinking about first responders. Typically, they're more concerned about everybody else that might have been involved rather than themselves. So they're not noticing very much right away. And then a few hours later, he did notice, he had some rib pain, headaches, dizziness. He was feeling very slow physically, just overall fatigue, and just kind of feeling out of it in general. And he was transported to the ED by EMS, and in ER fashion, as we talked about, they recommended him to alternate between Tylenol and Motrin and to engage in cognitive and physical rest. And I will say when it comes to the ED, they mean best. Their approach is to acutely treat all of the injuries and illnesses that they see coming in. They're not worried about long-term care. They're just focused on the immediate and then go out, see the other providers that you need after that. And so within that first 1 to 2 days, maybe that rest, a little bit of laying low key is okay. But then as we see, he also went to urgent care within the next few days, who continued that rest protocol for him, told him to remain out of work. They did give him some cholesterol for his rib pain, so at least some relief is happening there. And then he was also seen by the medical providers with his department, who also promoted this approach of resting. And so in natural fashion, if you have 3 different entities telling you to rest and not do a whole lot, that's what you're going to do. And so he was not working, not engaging in any sort of physical activity. He wasn't going out anywhere. He was staying in his basement, wearing sunglasses inside, not doing a whole lot. He was engaging in some cognitive activity. He was reading a little bit. He was coloring, doing some puzzles. But these activities were provoking a lot of fatigue for him. And that's going to be an important piece that we'll see come together a little bit later. And so what do we know about rest? What have we learned? Yes, it is not good. If there's anything you guys take away from this, rest is not best. And so he came to us 7 days after his injury. He was not feeling the best, as we mentioned. He's been pretty much locked in his basement for an entire week, not doing anything. And so he had a constant headache at a 6 out of 10 severity. He was experiencing some dizziness, nausea, light and noise sensitivity. As Brett mentioned, if you're locked in your basement for 5 days and you come out into the world of smoke, you're going to have some sensitivity to things. He was also not sleeping very well. All the cognitive difficulties, trouble concentrating, feeling forgetful about tasks he needed to do, what his intentions were, things like that. And a lot of increased emotion. So he was feeling very irritable, more anxious and nervous than he usually is. And he also reported these instances of panic, so kind of like small panic attacks that he was experiencing. And one thing I haven't mentioned yet is our police officer is also a combat veteran. And a big thing that I see with my combat veterans is they come in after a head injury and they say, I'm having a lot of PTSD symptoms. They say, I've had these symptoms managed for the last however many years, but since this injury, the hypervigilance is way increased. They're scanning for threats everywhere. All the classic PTSD symptoms have come back to them. And what I tell them is that the brain and the body don't know the difference between being in a combat zone with IEDs all over the place versus a motor vehicle accident in Northern Virginia. All it knows is that something very sudden and something very life-threatening happened, and suddenly they think they're back in theater with chaos ensuing all around them. And so we see a lot of that. And that can happen with any PTSD experiences. Again, like the brain and the body, they just don't know the difference. And so coming to his history, he has never had a medically diagnosed concussion, but being law enforcement and being prior military, he has been exposed to several head injuries, both impact injuries and blast injuries, and other motor vehicle accidents. He does have a history of migraines and headaches, which we know is a risk factor for prolonged recovery. And he also has been diagnosed with obstructive sleep apnea, so that is not helping his sleep difficulties. He was not yet using a CPAP at that time. He was still waiting for it. He had been recently diagnosed. And then he also had some prior neck injuries beforehand. And I think I forgot to mention that one with all of his symptoms. He was having a lot of neck pain and limited range of motion. He also has a history of generalized anxiety, post-traumatic stress disorder, and depression. He was on medications for depression. He was prescribed anxiety medications, but wasn't taking those. Again, he felt like his anxiety and PTSD was pretty well managed up until this injury. He liked to go hiking, reading, playing his guitar, spending time with his family, going to his daughter's competitions. Those are all really important protective factors, and they're going to help with that behavioral regulation and activation piece as part of his treatment plan. It's one of the ways we like to really individualize things for our patients. And then he does also have the family history of headaches and migraines and anxiety and depression. So he's kind of got that from both ends, both his personal side and family side. And so when we look at the different profiles that we talked about, on the right side of the screen, they're listed in the order in which our police officer reported the severity and what was bothering him the most. So based on the self-report questionnaire that we give regarding symptoms, patients are rating 29 different symptoms on how much they bothered them in the last few days. And so his neck pain and the limited range of motion was what was bothering him the most, followed by the sleep difficulties he was experiencing. And then he was reporting a lot of ocular motor complaints and we'll talk about that on the next slide, kind of see where all that comes in. So migraine symptoms, if we're thinking about the headache, the vestibular was after that, a little bit of dizziness, and then the cognitive fatigue and anxiety profile. So that's the order of everything and how they were bothering him. On the self-report mood inventories, he did endorse a mild level of depression. The level of anxiety he reported wasn't considered to be clinically significant, but he was right below the cutoff there, so it's still higher than what we would like to see. His neurocognitive testing wasn't the worst, wasn't the lowest that we've seen, but it also wasn't what we would expect given his educational and work history, especially for his reaction time. That was below expectation. That's one of the lowest descriptors we can give based on someone's percentile, what they're scoring in. And then his symptoms also increased following testing, which is a good indicator for us that there's definitely something really big going on here with all the different systems and how they're impacting how he's feeling. And then when it came to the VOMs, that's the vestibular ocular motor screen, he didn't have any symptom provocation with any of the different moves. Dr. Hill motioned one of them, so he didn't have any headache, dizziness, nausea, or fogginess be provoked with any of those. And so that's a good indicator that there wasn't any vestibular sensitivities going on. So even with that dizziness that he was reporting, now we're thinking about, well, what else might be contributing to that dizziness because it wasn't provoked with these movements. He did have a mild headache throughout it, but it didn't get worse in any way with anything. But then his convergence. So convergence is near point of convergence. And what we do is we have the patient hold a stick that has three colored circles on it, and they bring it as close to their nose as they can, focusing on the circle, stopping if that becomes double. And so we're looking to see how close they can get it before they're starting to see double, and whether or not one of their eyes also deviates or kind of moves outside. And that'll let us know if one of the eyes is a little bit weaker than the other. And normal range for convergence, based on the research, shows that it's between 0 to 5 centimeters. So if anything is outside of that, we're looking a little bit more closely at the eyes and the ocular system to see how they might be contributing to the symptoms. And so you can see his measurements were a little bit variable, but they were beyond that 5 centimeters. And you can see it says convergence initially, so that's during the initial appointment or the initial evaluation. And then we have them go on the neurocognitive testing. And typically when someone is reporting some ocular complaints and we see that their convergence is receded, it's farther out than what we would want it to be, we'll test the convergence again after testing. So if you think about it, especially if you haven't been doing anything for a whole week and now suddenly you're sitting at the computer, spending 20 minutes just focused on a screen, trying to track things all around, trying to remember things, your eyes are using a lot of energy. So if that system is involved in the symptoms, it's going to show up. Those eyes are going to be a little bit more receded after testing. And if you remember back to his first initial complaints, he was doing some reading and coloring, things like that, and that was provoking fatigue. Again, if we think about our eyes and how much they're taking in, even in a 1 second period, there's so much stimuli coming in. There's very small muscles guiding the eyes, so they actually use a lot of energy from the brain. It can provoke a lot of fatigue. And so that makes sense now that he was feeling so much fatigue, even though he wasn't doing a whole lot. And we see that even after testing, his convergence was receded beyond what we would expect it to be, both with that stick that I mentioned, and then we also have this very fancy tool made of yarn string and 3 beads, and he couldn't track in the bead nearly as close as we would like it to be. And so based on all of this, at the end of his initial evaluation, we did give him a primary profile of an ocular profile, meaning that the ocular system was contributing the most to the symptoms he was reporting and the difficulties that we were seeing on all of the objective testing. We also added in the anxiety and mood profile just because he was reporting that increased depression and anxiety and how that might have been contributing to just overall disruption of his lifestyle. And then, of course, we have the sleep and the cervical modifier. He was not sleeping well, so that's certainly influencing symptoms. And then he was having a lot of neck pain and, again, the limited range of motion. So that can also be contributing to limited activities and also some of these symptoms, especially like the headache and the dizziness. And so we gave him our typical behavioral regulation activation. We did ask him to start to come off of the Tylenol and the Motrin to reduce the risk of any rebound headaches. That's a big thing that we see in our clinic is people come in, especially after 3 or 4 weeks of taking Tylenol every 4 hours. Now we're trying to figure out, is this still a concussion-related headache or is this more of a rebound-related headache? Normal improving hydration and nutrition, making sure he's eating, staying consistent with all of those. trying to regulate his sleep and just generally increasing his daily activities. Again, he hasn't been doing a whole lot for the last weeks. We want him to start to get back into gradually exposing himself to those activities that he enjoys. We did give him some home neck exercises to start to stretch and strengthen his neck to increase that range of motion, relieve some of that pain there. And we did also recommend that he work with his department's athletic trainer to try to work through any other cervical discomfort that might be going on for him. And then for the ocular profile, we did give him some pencil push-ups. And again, we give patients their own little tongue depressor with a dot on it, and they're bringing it in close, stopping when it gets double, and pulling it back out. So they're really just doing push-ups with their eyes. It's kind of fun. We did recommend that he stay out of work for about 8 more days just to help him get regulated. We wouldn't want to throw him back into work after he's been locked in his basement for a week. We need to gradually expose him back into the world, getting back out there, start to bring down some of these symptoms. And then we recommended him to return full-time with light duty. We didn't want him going back full force into things, but starting with, desk duty, admin duty, things like that. And then we did want him to engage in light to maximal non-contact physical activity. Again, we determined that his dizziness was not related to the vestibular system, so we wanted him to start working back up to his maximal exertion. And so we saw him for his first follow-up at 4 weeks after his injury. He was feeling a little bit better, but still not feeling the best. He did stop the over-the-counter medication and thankfully did get his CPAP machine, so he was starting to use that, which was helping sleep improve quite a bit. He was engaging in the home neck exercises. Unfortunately, he was still experiencing a lot of cervical discomfort and pain and limited range of motion. And he was also doing the pencil push-ups, but again, still experiencing a lot of headaches, trouble concentrating, and the ocular motor difficulties, especially when he was on the firing range. And so if anyone has shot a 9mm before, you know that trying to line up the front and rear sights, in addition to trying to line up your target, your eyes are using a lot of energy there. And so it makes sense that he was having such difficulties there since he has this ocular profile that we're trying to strengthen back to normal. No longer experiencing any significant symptoms consistent with depression or anxiety. His panic attacks were coming back down. There was a lot of improvement there. Still no symptom provocation on bombs. Convergence was a little bit better, still pretty borderline at that point, right around that 5 to 6 centimeters. We did not repeat testing at this point. We typically wait until our clearance visit to make sure cognitive abilities are back up where they were, so we'll see where that comes up shortly. And so at this point, we realized the home neck exercises were not enough for him. He did need some official cervical PT, so we recommended him to start that. We also gave him the fancy Brock string, so the pencil push-ups were doing their job, but it wasn't helping as much as we would like or getting into that full level of healing. So we gave him the Brock string to push that a little bit further, and then to also keep increasing his physical activity. And then his second follow-up was 7.5 weeks after his injury. Again, he was starting to feel a lot better at this point, but still having some difficulties. He had went on a trip where he was riding some roller coasters. He was feeling pretty good, but was getting some headaches with those. And he was back to his normal level of physical activity, which is great and what we want to see. And he wasn't having any symptoms with physical activity, which is a great sign for us, especially at this point. He had only done 1 session of cervical PT by this point, just because he had been traveling quite a bit. So he's still having some cervical discomfort and limited range, but they were starting to work through that. And he had also been using the Brock string with a benefit there. And he was still having some headaches, some fatigue, some trouble focusing, kind of the classic symptoms we see take a little bit longer to clear out. Still no depression or anxiety symptoms that were impacting him, no symptom provocation on bombs. And we recommended he continue with the cervical PT and keep using the Brock string to really strengthen in those ocular muscles for full resolution. And then 12.5 weeks post-injury, we see him for his final follow-up. And he reported that he had been symptom-free for about 3 to 4 weeks at this point. And it took so long to see him again. He had been traveling quite a bit. So thankfully he was out enjoying life, which I think helped, with that behavioral regulation activation piece. But so if we think about that, he had been symptom-free for right around that 8 week, or symptom-free about that 8 weeks post-injury. He was still doing his cervical PT and his home exercises with that. He had stopped the Brock string because he stopped noticing any ocular difficulties, so we were pretty confident things were good there. He was back to working full-time without any symptoms, both in the admin sector and more out in the field and in the firing range. Everything was going good for him there. He was out doing social activities. Like I said, he'd been traveling quite a bit, going to all these busy environments without any symptoms or any difficulties, which is what we hope to see. Still no depression or anxiety, no symptoms on bombs. Convergence was back to within a normal limit for him there. And he also showed improved cognitive performance across all domains, and we'll look at that, what that looks like on the next slide. So based on all of this, he had been symptom-free for a few weeks. We determined that he was cleared from concussion treatment. The concussion had resolved. He wasn't experiencing any difficulties still related to it. We did recommend that he continue with this course of cervical PT just to further heal his neck and hopefully prevent any long-term difficulties there, especially since he does have the history of Parkinson's. And so I know this slide can be a lot and a little confusing, but this is what shows up for our cognitive testing. It's broken down into verbal memory, visual memory, processing speed, and reaction time. And this middle column are his scores at his initial visit, so where he was low average for both memory domains. Processing speed was average, but then his reaction time was below expectation, so a lot lower than what we would want to see for him. But then at his final visit, which is the third column, we see that his verbal memory, visual memory, and processing speed were all superior. They significantly improved compared to what they were before, and now they're at the top end of the percentile range for his age group. And his reaction time also came up to above average. So he went from the 8th percentile to the 90th percentile. So I think that shows, and again, this was, 3 to 4 weeks after he had been symptom-free. So this shows like just the power of that cognitive testing and how it can really show when symptoms have fully resolved, especially that cognitive piece. And so again, we cleared him and he was ready to go back to work full-time, full duty, all the fun life activities that he likes to do. And just quickly, I'm going to go through some research initiatives and insights. So the first two, kind of some heavy topics within the world of concussion. The first one is using the term post-concussion syndrome. And this can be problematic because the word syndrome is essentially just a cluster of vague symptoms that we don't know what's causing them or where they're coming from. So if anyone's heard of the Gulf War syndrome, again, it's just a cluster of symptoms that veterans or service members, serving in the Gulf War come back with. No provider knows what's causing these symptoms or where they're coming from, and they're just kind of left with this defeat of, I'm going to experience this forever, this is permanent for me, nobody knows what's going on. And the same thing can happen with post-concussion syndrome. Essentially, it places a label to say, well, we don't know what's causing your symptoms, and this is just going to be it. But as we've learned, we know that concussion is recoverable, it is treatable, and so using this term can actually be pretty harmful as it kind of creates this notion that you're going to live with these symptoms forever. But if we shift more towards the persisting symptoms after concussion, it gives it more of a symptom-based approach that we can look at the symptoms, what systems are causing those symptoms, and how can we promote that individualized treatment to allow a person to reach their full recovery after the concussion. And the next one is CTE, chronic traumatic encephalopathy, which is a very big word in the sport world and just kind of in general right now. We'll always a lot of talk about that. And essentially, this is a condition where there's abnormal tau proteins accumulating in the brain. And it can only be diagnosed post-mortem, but there's a lot of talk, especially in the NFL, about how these repeated head injuries can lead to CTE and things like that. But if we look at the bottom bullet, we see that having a history of repeated head injuries is found in athletes who are later diagnosed with CTE, but not all athletes who have repeated head injuries are diagnosed with CTE or are found to have this tau accumulation. The CTE pathology has also been found in non-athletes who have never had concussions. And so at this point, there's not enough research to show one way or another. And again, it can be pretty harmful to kind of say, oh, CTE is only caused by head injuries, or that anyone who has a head injury, especially 1 or 2 head injuries, is going to develop CTE. And so there's still no consensus on what exactly causes CTE. There's still a lot of risk factors being explored, and that's one thing. The research is still very conflicting. You know, no research is ever perfect, but we're still very far from actually understanding what this is and how head injuries contribute or don't contribute to this pathology. And so next, I'm going to talk just very briefly about a few research projects that have been done through Inova's sports medicine clinic specifically. So the team recently published a paper looking at the long-term health-related quality of life in patients that we treated with our model. And spoiler alert, what we found is that those who we treated had no evidence of any long-term effects from their concussions. And so our patients were making full lasting recoveries from their injury, which is great news. And so what they did is they sent a survey to patients that they had treated within the last 6 years and asked them, do you perceive yourself to still be recovered from the symptoms and the difficulties you're experiencing related to your concussion? We had 83% of patients say yes, they felt like they were still recovered and living a quality life, which is absolutely amazing. It's a very high percentage. But we did have 17% that said no. And so what about those 17%? Well, looking further into the data, it showed that this 17%, they were more likely to have experienced a negative self-event, like a negative life event within the previous year of receiving that survey. And they were more likely to have a history of anxiety and depression. And so again, this just highlights that role of stress, the role of mental health in creating some of these symptoms and how it can shape someone's perception of what's related to what. It's a lot easier to attribute symptoms to a head injury. You know you hit your head, but we can't see depression, we can't see anxiety, we can't see stress. It's a lot harder to kind of attribute the symptoms that we're feeling, you know, to the emotional side rather than the tangible physical side. The good news is that none of the injury-related factors were shown to correlate with them not perceiving full recovery. So things like their symptom burden at their initial appointment, history of concussions was not correlated with not having a perceived recovery, all of that. It was more that negative life event more recently and the history of anxiety and depression. And then a really fun study that the team has done, and we're actually in our second installment of this, is using digital health to track concussion in between our appointments. So when it comes to our seeing our patients, we're seeing them every 1 to 2 weeks after their injury, but there's about 6 to 13 days in there that we don't actually know what's going on. We don't know what they're doing, how they're feeling in those days. And we want to try to find a better way to track concussion during that full week or 2 weeks that we're not seeing them. And so in collaboration with Penn State, the team developed an app that was sent out to the patients. They sent a survey 4 times a day through the app, asking them about their symptoms, what they had been doing since the last survey, like what kind of environments they were in, if they engaged in physical activity, any cognitive activity. And then they also sent them a brain game with each survey. And it's just a short brain game to look at cognitive activity, specifically reaction time and processing speed, to see how things were trajectorying throughout the day. And what they found was that most patients really enjoyed using the app. They felt like it was giving them something to do about their recovery. They weren't just kind of sitting and waiting. They were doing something proactive about it. They were being able to track things and engage in things, and it helped to encourage them to get out and do things a little bit more. And then one of the big highlights of the study is that it helped to solidify the presence of the cognitive fatigue profile. And Dr. Hill was a very big skeptic of this profile when we started out. We don't see it a whole lot, but essentially the cognitive fatigue profile is patients, they're not feeling a whole lot of physical symptoms. They're not having that headache or nausea, light and noise sensitivity, things like that. They're just reporting that trouble concentrating, and then they're saying they're okay in the morning, but then by the end of the day or by mid-afternoon, they're just totally wiped out and they don't know what happened, but they can't do anything anymore and they just want to go to sleep for the rest of the day. And so this app allowed us to see, based on those brain games that they were getting, that people with this cognitive fatigue profile, their performance was steadily decreasing at each time point throughout the day. But if someone didn't have that profile, their scores were stable throughout the day. So it really helped us solidify that for us and try to help promote further interventions and treatments to help recover that profile as well. I apologize for going over, but we are at the end now. So any questions?
Thank you guys very much. That's a very interesting topic, and it's got a lot of controversy. Those I just saw ESPN awarded $18 million to a college athlete, and
Occupational medicine standpoint, just want to make you aware. The one that's exactly like, it's not exactly part of this, but if somebody's on a ladder and they fall off the ladder and they have a head injury, is that workers' comp? Is that workers' comp? You understand? I mean, depending on the platform, people candidate for that. Is that workers' comp? You need a platform and you want to shovel. Yes. Somebody loses consciousness and on the way down, puts their head against the table. Is that workers' comp?
In the federal system, yes, but the table got in the way.
This is actually true. If an employee is standing there and has an epileptic seizure or has a diabetic problem, has a loss of consciousness, falls down, hits their head on the ground, the most legislative, the most judicial environment, that's not workers' comp. Not workers' comp. Like a heart attack. This is workers' comp. And it's not. You need to be very careful about the history you take and to understand where that claim is going. Because you could treat someone for weeks and then reimbursement you got. Be aware of that. I also say, when we talk about concussion, we talk about the cerebral cortex, brain stem, related to physiology. I got a couple of cases that was hippocampal gyrus injury. And things like inability to process new memory. So, one interesting thing came in and she hit her injury every day in the morning. Has to play a videotape to remind her that she has children. And she would often wake up in bedtime at night and say, "Why are you in bed with me?" Because her memory stopped at the point at which they were engaged. And that injury actually didn't. And it was pre-existing brain malformations may lead to more permanent things that may not pick up on MRI.
Sure, and I think it's important as we talk about this to understand when we deal with any kind of structural injuries beyond just that efficiency, inefficiency at that cellular level, we're dealing with an injury beyond concussion. We're adding something else to it. So anytime we have a bleed or some sort of structural injury, one malformation, or any kind of arachnoid cyst that kind of inflames those kind of challenges, that's bringing something else in beyond concussion as well.
Just be careful. I mean, 2 weeks ago, the MRI that we picked up on it, developmental venous abnormality of the cerebellum and persistent so just be aware that it's going to be more complex.
Anybody else have any questions? Okay,
On the chat.
with that, I'll wait. There's a question online that I would like to read to you by Dr. Rivera. She's asking, we do everything possible to keep people at work. You mentioned that for athletes going back to playing and prolonged recovery. Is there any data for workplace? Does sending people back to work after a concussion increase recovery time? If so, for my workplace head injury with symptoms like headache, do you have any guidance on restrictions so individuals can continue working without prolonged recovery? Will you guys address some of that stuff with your research and everything else? But if you don't mind.
Yeah, real simple. When we talk about athletes and prolonged recovery, that's that immediate, like, I hit my head, I know I have symptoms, and I stay in the game. Right? This is not the next day or when we talk about that behavioral regulation. This is that immediate, I haven't taken myself out. And so for workman's comp, that really applies to on a fire ground or in a scenario where a worker may have hit their head earlier in the day, but neglects to report it and continues with vigorous activity throughout the day. Those cases may end up with a prolonged recovery. With regard to the return to work strategies, as we talked about, this is really encouraging that modified schedule, using breaks throughout the day, trying all the different strategies we can to keep patients engaged in their regular daily lifestyle as much as possible. I think that's the simplest thing.
And then I'll just add one more thing to that. I think this is something we talked about, but we didn't emphasize specifically. With this injury, you have to experience symptoms in order to get better. And like Courtwright talked about the exposed recover model, if symptoms are anywhere between a 0 and a 5, that's the keep going range. We get to a 5 or above, or if it's a 2-point increase in previous symptoms, let's say you were at a 4 out of 10 headache before, now you're at a 6 out of 10 headache, that's the close way to take a break. And so taking a break is to help bring those symptoms back down to a more tolerable level, and then you return back to the activity that you were doing before. Even if you are still symptomatic, if you're within that range, we need to help recalibrate the brain back to what's a normal activity. But like I mentioned with the cycle of avoidance, those symptoms start to come down over time eventually. So if someone's doing something and they are experiencing symptoms, that's okay. But you need to be able to take breaks throughout the day to help bring those symptoms down, or else you hit that crash effect at the end of the day, like we discussed too.
The resource I just mentioned, if you deal with concussions at work, then you go home, call your local school district, talk to their school nurse, and get a copy of their return to play protocols. Return to class and return to play, because they've got graded activities and they'll give you an idea of the structures you can use in returning to work. Just get past the school nurse.
Anybody else have any questions?
2 points. I was impressed with the police case that the emergency room prescribed Motrin and NSAID following his report of hitting the steering wheel with his head. And I was always advised against that 24 hours. One, that would affect anything in your expectation of care. But the other one is a little bit more esoteric. You earlier mentioned that the NFL is funding a lot of the research. Do they have unrestricted grants, or are there like stipulations? Because I was once told years ago by a mentor to be very wary of who's giving you money, because in his case, this was allergy immunology. The company mid-study said, we're not going to continue this because we don't like the way your data is looking.
The answer to the NFL question is just yes, right? I think that there are both sides of that. There are restricted grants and there are unrestricted grants. And I think that's where you have to look at the research and appreciate the study. One of the biggest ones out there right now is Boston University, and that's the one that's he and David Banker brings to look at CTE. And I think there's a lot of funding behind that and a lot of general bias in the study that we have to continue to appreciate and ensure that that's not influencing the data that we're collecting. And that's why when Dr. Courtwright talks about CTE, the most underlying important statement of that is we need to continue to stay tuned and we need to let the research evolve and understand exactly what's going on. There's too many variables right now that we don't have a full grasp on with regards to how we manage it. The first part of the question with regards to Tylenol, the slide I apologize. With regards to medications, going back to the fundamentals of concussion, there shouldn't be a structural injury with regards to that from a standpoint of an NSAID or an anti-inflammatory. We don't see much of a factor. Beyond that 24-hour period, I always heard that well, but beyond that 24-hour period, we always recommend what the family use as appropriate for them. If you're from kind of the Western area, maybe goodies, headache powder is your thing, but Tylenol, Advil, everything's okay. A couple of factors, the slide that we lost with regards to medications. One is patients have no clue or just doesn't reach the top floor that Excedrin has anywhere between 75 and 200 milligrams of caffeine. And they take that at 9 o'clock at night and wonder why they're not sleeping. So again, education on that. Furosemide is very commonly prescribed in the ER, and that is a medication that, while it can really bring a significant headache, it has a very profound rebound headache profile, as we know, and that can get somebody in a very wicked rebound headache cycle pretty quickly. Again, also loaded with caffeine. Please understand these patients, it says 4 times a day on the bottle, they're going to be 4 times a day on the bottle right on. So be cautious with the medications. Last on the medications, any ADHD medications, mood-based stabilizers that are taken prior to this injury should be continued on a regular basis. They should not be disrupted because of this injury. We see that a lot with challenges, especially ADHD medication. Patients are not coming back to work, therefore they might not be taking those medications, and then they're altering brain chemistry and creating a large cognitive challenge across the board. So that would be my input on medication.
Well, thank you very much. Can we get another round of applause?
If you have a dialogue here, if you have any feedback, please hit up that last little QR. Thank you, travel safe. We greatly appreciate you inviting us to your conference.
Great, thank you for coming. Anything else? So, ladies and gentlemen, this concludes the conference. Thank you all very much on behalf of the planning committee for coming and attending and making this a successful event. We wish you safe travel.